All right. Welcome to the USMLE course series. This is our second podcast on pediatric gastroenterology. I will be talking about some of the high yield conditions that you need to know about for your step 2 CK. Okay, let's get into it. Duodenal atresia. What's that? So, when there is absence of your apoptosis, when there are apoptosis is what? Programmed cell death. If the apoptosis is absent, it leads to improper canalization of the lumen of the duodenum, right? So usually, duodenal atresia is also associated with Down syndrome and annular pancreas, right? And remember this, prenatal ultrasound, when you do prenatal ultrasound, it will show polyhydramnios because these patients, they can't be able to swallow and remove the amniotic fluid, right? Patients, the infants, they typically present with onset of bilious vomiting within 12 hours of birth. And when you do the chest X-ray, in these cases, chest X-ray will show air trapped in the stomach, and you can see the first portion of duodenum tube. So this is called double bubble sign, and there is no distal intestinal gas due to inability for gas to pass the duodenum. How are you going to manage this? So first, replace the IV fluids, electrolytes replacement. Potassium is often low from vomiting, so you need to replace it. NG tube must be used to decompress the bowel as well, right? The definitive treatment is obviously surgical duodenostomy. This is one of the surgical procedures you can do to treat duodenal atresia. What about jejunal atresia now? Intestinal atresia can occur anywhere. Atresia of the jejunum or ileum is usually occur due to vascular accident in utero. Vascular accident happened in utero, leads to necrosis there and resorption of the fetal intestine. What happens then? So there will be sealing off there and leaving behind the blind proximal and distal ends of intestine. Maternal use of vasoconstrictive medications or drugs like cocaine or tobacco, it can cause this thing. It can cause poor fetal gut perfusion there. So there is obviously vascular accident. This jejunal atresia or ileal atresia, it's not associated with any chromosomal abnormality. It's not associated with Down syndrome or something. The presence of triple bubble sign here in jejunal atresia and gasless colon on X-ray, like the stomach, duodenum, and jejunum, it's pretty much how you diagnose it. Treatment, usually you should focus initially on resuscitation and stabilization of the patient, followed by you can do the surgical correction for jejunal atresia. What about volvulus? Volvulus is a thing. It's a bowel obstruction in which a loop of bowel has twisted on itself abnormally. Usually, in children, volvulus occurs in midgut, majority in the ileum. And what's the primary factor that is responsible for volvulus? It's actually malrotation of the midgut during early fetal development. Midgut volvulus classically presents in a neonate with bilious vomiting. This is one of the very common presentation of volvulus, right? Initially, the abdomen is soft and not distended, but what happened with this, there is ischemia of the twisted bowel can happen. It can cause bloody stools, abdominal distension can happen, bowel perforation, and peritonitis, ultimately. Right? So what are you going to do in this? X-ray, first step to rule out pneumoperitoneum, right? Which would reflect the intestinal perforation, or we need for emergency surgery. If there is no evidence of free air and the bowel pattern is not suggestive of duodenal atresia or distal obstruction, then you can go for upper GI series, barium swallow. And upper GI series is very important here. It's the fastest and most accurate way of diagnosing malrotation with midgut volvulus. So they can ask you about the diagnostic features of midgut volvulus. So the ligament of Treitz on the right side of the abdomen, the finding there, it reflects right side of the abdomen, it reflects malrotation, right? And if you see corkscrew pattern with the volvulus, it represents your volvulus. So in upper GI series, if the ligament of Treitz is on the right side of the abdomen, it suggests that this is a case of malrotation. But if there's a pattern, corkscrew pattern is present, it suggests volvulus. what are you going to do for that? Surgical or endoscopic untwisting? Because, bowel necrosis will happen and leads to perforation and life-threatening sepsis there. And the best initial therapy is endoscopic decompression. We endoscopically decompress this, and if this fails, go with the surgical decompression. Right? So bilious emesis, if you see, this is one of the very important ominous sign. Bilious emesis, if you see in the neonate, suggestive of intestinal obstruction, and it requires immediate workup. So if the neonate is stable with all the bilious emesis, we stop the enteral feeds, we give the NG tube decompression, and we start with IV fluids. And you remember this, X-ray is generally the first step in the bilious one. Rule out pneumoperitoneum first, which would reflect the patient does not have any kind of intestinal perforation, or maybe if the patient needs emergency surgery. The diagnosis may be suspected if the NG tube terminates in abnormally placed duodenum too, but X-ray is usually non-specific for midgut volvulus. And if there is no evidence of free air and the bowel gas pattern is not suggestive of duodenal atresia, double bubble sign, or distal obstruction, go with the barium swallow, upper GI series, and you can measure it. This is very important. Right? That's how you evaluate. Abdominal X-ray first. If free air is present, go with the surgery. If dilated loops are present on X-ray, go for contrast enema. If contrast enema shows microcolon, we talked about microcolon and macrocolon. So if contrast enema shows microcolon, that's meconium ileus. If contrast enema has this rectosigmoid transition zone, this is a high subtrunk disease. If NG tube is misplaced, duodenum is present on X-ray, and then you do the upper GI series. And in upper GI series, you find ligament of Treitz is on the right side of the abdomen, and this is malrotation. And if you see the double bubble sign in the abdominal X-ray, that is duodenal atresia. That's how you evaluate the bilious emesis cases. Right? Okay, let's talk about intussusception. This is a very important condition in which your bowel telescopes into another segment of bowel. Distal stool, the proximal telescope distal. It can be, usually the cause can be polyp, right? Hard stool, hematomas, right? In hinoxinol and purpura, usually hematomas can develop and can cause it. Lymphoma can cause it, right? So anything that weakens that area. So any, viral infections can do that too. Cause hypertrophy of Pierre patches in that area and leads to telescoping. Right? And this is one of the very commonest and the commonest and important cause of intestinal obstruction in children with age 6 to 36 months. And what's the frequently involved place there? The ileocolic junction. Ileocolic junction with the invagination of ileum into colon. Right? So how do these cases present? Usually with number one, abdominal pain, colicky abdominal pain, a lot of pain, bilious vomiting again, and very important, the patient will be having bloody and mucosy stools. These are called current jelly stools. Right? Maybe sometimes, intussusception is palpable as a tubular sausage-shaped mass in the upper quadrant as well, right upper quadrant. Right? Where do we hear this current jelly thing before? Yes, in Klebsiella pneumonia, in lungs. As a sputum, we see the current jelly as well. Right? So ultrasound is very important here. It's one of the best initial tests. And what are you going to see on ultrasound? That is important too. We see target sign or donut sign. Right? Ultrasound guide air. This is very important. Ultrasound guide air contrast enema can lead to non-operative reduction of intussusception. This is the procedure of choice for diagnosis and treatment. And we can use saline enemas as well. So very important. Ultrasound guided air contrast enema can be used here. Fluid resuscitation and obviously the balancing of electrolytes, these are the initial steps here, right? And we can do NG2 compression of the bowel tube. If enema is not curative, then obviously go with emergency surgical intervention to prevent the bowel necrosis. So air or saline enema, very important, right? Okay, next thing is Meckel's diverticulum. It's a true congenital diverticulum, all three layers. in which the vitelline duct persists in a small intestinal tract. And Meckel's diverticulum is the most common congenital small intestine anomaly, right? So what happens with that? There's an incomplete obliteration of omphallomesenteric duct that actually connects your midgut and yolk sac early in the fetal life. So there's an obliteration of that thing, right? These omphallomesenteric duct, right? So mostly, these people, these child, they're asymptomatic. Probably the incidental finding here. 2% of the cases, they can become symptomatic. Painless hematochezia. This is the most common presentation, painless hematochezia, right? If there's ectopic gastric tissue there, right, it leads to secretion of hydrochloric acid and cause mucosal ulceration there, right? Bleeding is substantial bleeding can happen too. And the diverticulum, may also become inflamed and simulate the clinical presentation of acute appendicitis. So remember the rule of twos here. 2% of population, patient age less than 2. Male patients 2 times more affected. Only 2% are symptomatic. 2% ectopic tissue like gastric and the pancreatic. Occurs 2 feet from the ileocecal wall and about 2 inches long. Right? So what's the diagnostic test you're looking for? Technetium 99M per technetate scan. This is called Meckel scan. This is how you diagnose it. Accumulation of these per technetate in the lower abdominal quadrant is the diagnostic of Meckel's diverticulum that contains your ectopic gastric mucosa. Patients receive this amount of technetium and we check with the gamma camera, right? Although, the bleeding usually resolves spontaneously, but surgical resection is necessary here too to prevent the further bleeding or other complications like intussusception or complete obstruction, right? So painless lower GI bleed with anemia and the complications can happen with this, right? Treatment is surgery. That's it. Right. Okay, let's talk about necrotizing enterocolitis. This is one of the most common GI emergency in the neonatal ICU. And what's the mortality rate of the necrotizing enterocolitis? It's 30%. It's usually seen in only the premature infants, where the bowel undergoes necrosis and bacteria invades the intestinal wall. So because the gut is immature in this immature condition, right, in premature cases, it exposes the bacteria from enteral feeds, leads to cascade of inflammation and damage to bowel wall. So what happens there? This premature intestinal mucosa have increased permeability and bacterial penetration, right? So it leads to decreased motility or bacterial growth too. So if possible, premature infants should receive breast milk instead of formula. Why? Because some studies suggest that decreased rate of this necrotizing enterocolitis in breastfed premature infants as breast milk may counteract some of the problem with gut immaturity, right? So this poorly perfused intestinal tract there may have reduced ability to complete digest and absorb. It leads to bacterial fermentation there, excessive mucosal inflammation there, right? Although 85% of the cases in these infants, they are premature. 85, they have low birth weight. But term infants, they can come too with mesenteric perfusion from congenital heart disease. And, up to the 30% of these cases, they die. Premature with low birth weight, abdominal vomiting and abdominal distension with fever. This is a case of necrotizing enterocolitis. And the important thing is you need to know is diagnostics here. Abdominal X-ray you will be doing, and it's a pathognomonic as pneumatosis intestinalis. This is the air within the bowel wall. And, and when you do the CT scan here, CT will reveal air in the portal vein, dilated bowel loops here, and pneumoperitoneum, right? In normal abdominal X-ray, air is visible only in the lumen of the bowel, right? When we talk about the normal abdominal X-ray, air is only visible in the lumen of the bowel. But in cases of necrotizing enterocolitis, the air is visible in actually whole bowel wall. This is a hallmark finding. We call it pneumatosis intestinalis, right? And branching areas of lucency can occur on the liver as well, because they're about portal venous air present too, right? occult blood, frank blood can be seen in the stool too. What are you going to do? Because this is one of the emergency. So first, needs first. So feeding must be discontinued for bowel rest. IV fluids must be started immediately. NG tube must be placed for bowel decompression. NG tube should be done. IV antibiotics. And if medical management does not lead to resolution of this, then surgery is indicated to remove the affected bowel. Survivors, they are usually at risk of strictures and bowel obstruction secondary to fibrosis that occurs there. So usually go with the bowel rest, IV antibiotics, and if medical management does not work, surgery should be done. Right? Okay. I'm going to talk about umbilical hernia here because this is very important too in pediatric gastro. Umbilical hernia is what? When you have incomplete closure of the abdominal muscles around the umbilical ring. Around the umbilical ring, if you have incomplete closure of abdominal muscles at birth. There are so many associations with umbilical hernia. African American race, prematurity, Ehlers-Danlos syndrome, very important. Backwith-Widman syndrome. Remember in Wilms tumor, Backwith-Widman. Hypothyroidism, cretinism is very important here. So when you do the physical examination in these cases, you will be seeing soft, non-tender bulge covered by skin and which protrudes during crying, coughing, straining. And the hernia may contain omentum there too, or some of small portions of small intestine as well. Most hernias, they reduce easily, low risk of incarceration and strangulation. And they can, we don't need for small hernias, we typically don't need to manage it. They close spontaneously by concentric fibrosis and scar tissue formation. Right? But in large hernia, the patient can have medical issues. So around age 5, we can do the surgery. It is recommended to do the surgery around age 5. This is the question they can ask you for persistent hernia. Right? So this is all about today's podcast. And I will be doing the pediatric gastroenterology part 3 as well, because there are some more conditions I want to talk about. In the next podcast, I will talk about them. I hope you get this lecture and please leave a review. Thank you.